Good morning. This is Lieutenant Adam Fritsch. I am going through a sample ePCR today on fireworks. And this is something that we're looking to share so that we can get everyone on the same page with this. There's been lots of new memos and information, and this is just a sample to make sure that we're covering some things. I reviewed a few last week and found some pretty consistent problems. So I want to bring these to your attention and go through a pretty methodical way of doing this. So let's get into it. We will start with our patient. Boy. All right, so Yosemite Sam probably looks familiar. Appears to be a shark bite, and in this shark attack, looks like he was bit by the animal and maybe has a concussion now too. Poor guy. So we're gonna go to our ePCR here on our tablet within the ambulance on the way to the call. And I've already started this one. This is the incident number that correlates to this call. And then in order to add the ePCR rather, this is the add button, and I've already got it open. So I'll go to that one. Remember, when you add it, it's going to ask what unit are you on, so it can populate that in the report. And this is what you get. First most important thing is to make sure that your crew is accurate. So whoever started this, whoever was signed into it, your name is on here. If you didn't quite make the cut, the call was at 6:02 and you hadn't gotten on the tablet yet to adjust the right information, make sure that you get the names of the crew on here so that the right people can be added to the report and the right people have access to edit it. So I'll add my crew here. And then we're responding, we get on scene, we find Sam. He's suffering from this concussion and his shark bite. So first thing that we're going to do is, of course, go to our patient and start caring for him. And then on the patient tab, I'm going to get a bystander or find his wallet or the healthcare provider, whoever knows who it is. So that's Yosemite Sam, and that's a male, and his date of birth is on his ID. He's quite old. There he is. Populates our age. And now when we're on our way to the hospital, we will have the right demographics so that the hospital can get that information right away. Most important things. Down here, we know that the patient's address often is where the incident is, so we can copy it from the incident. If it's not, then we can put in theirs, but that's something we can do later. So demographics, most important stuff is already in here. As far as what we're doing in the call, a lot of times there's people that are working with the patient. There's someone else that maybe has the tablet and is working on this. So a lot of us I've seen go to the narrative and click on that and enter things as we're doing them. So for example, your blood glucose, you put in here, maybe some other assessment management things you did, your IV start times, things like that. And then you save that. The problem with that is when you go to verify your report is complete, there is something in this box, and that's what the system is going to say is, okay, everything looks good because there's something in the box. And we've seen a few times where either a narrative isn't put in or it isn't saved. And that's probably because it checked okay when you click the complete ePCR because something was in this box. So one other tool that you can use that many people don't know about is this quick actions. And yep, we'd love to do that. But for our purposes right now, you can see some hot buttons up here, right? Patient info, some critical fields, some medications, some procedures, some vitals, modify the crew, and then your quick signatures here too. This is kind of your action panel, right, of the important things you need to do. This is most useful and really designed for like a CPR circumstance, right? So of course we're using the monitor, we're doing the appropriate things on there, but then besides that, we could also be using these hot buttons to make sure that we're timing things out appropriately. For example, I'm going to start the timer on here and you'll see this go. And then as I'm doing certain things on here, they'll appear in this summary. So for example, we were doing CPR, I could click that. We do our first shock, we could click that. We resume CPR, of course. We get IV access or IO access. We can add those things very quickly. It does not have to be a code for you to use these features. So we're not going to use the timer on this one because Sam is doing okay right now. But let's say, for example, that Sam was having some trouble breathing after his attack and we put him on oxygen. We can do oxygen and that adds it to the list and it timestamps it for us. We start the IV, we do a 3-lead, so on and so forth. If I want to do other things, I could click a critical field thing, and that would take me to some of those. I could do quick medications. This would do more about the medication and a more extensive list here. If there was something I wanted to add to the vital signs, I could do that. Although remember, we're typically going to import those from our monitor. Maybe I wanted to do something with the crew or the signatures is important, of course, at the end of our call rather than clicking around in here. So the great thing about this is the lightning bolt. These are some quick actions that we can do. There are some other buttons up here. In the interest of time, I'm not going to go through all of them today, but there is some helpful features up here too that a lot of people are not using, the lightning bolt being one of the more important ones. Okay, so I'm running my call. We're doing our stuff. A couple things that we typically do during the call: under patient, under medical history. We can answer some of this. It's a good reminder, like when's the last time you had something to eat or drink, maybe some advanced directives if we have that information. Some things to be on the lookout for. When I click the medical surgical history, for example, commonly used is up there first. So a lot of the common things that we hear, like hypertension, is on this list. Sam probably has a lipid problem, and he has a lot of anxiety. But that's not what that says, is it? So where are the other ones? Well, under recommended, you'll get a much more extensive list, right? One of the complications that we see is that sometimes people just pick something that has the word in it. Is he actually been diagnosed with an adjustment disorder with anxiety, or does he just have anxiety, an unspecific anxiety disorder? Or if you're not sure, just do another anxiety disorder. His is mostly related to the fact that he gets fooled by animals all the time, right? So we'll just put that one for now. But be very careful because some people are accidentally clicking some of these other ones just because they have the word in it, the first thing that you see. Just be on the lookout for that. When I hit apply, they all populate. We'll see the same thing under medications, right? We see a lot of people typing medications under other current medications, and we'd really like you to use this one. I know it's a little bit more of a pain. Metoprolol, for example, he takes for his blood pressure. He probably takes Lipitor. Oh, it's not coming up on my list. How is that possible? There it is, under recommended. So the same thing as the medical procedures under medications. If you go under recommended, it has a little bit more extensive of a list. And then, for his anxiety, he probably takes some kind of Xanax or something like that too. That's on this list. Remember that there are some things that are combined with other medications. So I'm going to go back to metoprolol, and you'll see what I'm talking about here. There's several different combinations on here. Be very careful that what you're listing for medications is the actual medication. So perhaps he does take metoprolol with the nifedipine, but if it's just strictly metoprolol, we need to make sure that we're clicking the right one. Most of our commonly used are just single medications, but be on the lookout for some of these because there are some combinations, and we've seen where people are clicking something that has metoprolol in it because it's the first one that populates, but that's not necessarily the correct medication. It should be this one. So just keep your eyes open. All right, so we've done a great job getting all these medications in, getting some history. We're on our way to the hospital. We make our telephone call, done all the right things for this patient, and we get to the hospital, either by using signatures, or we could do that quick action if we're already on that one and do the quick signature on here. This is what populates. I want to point out that typically your EMS crew and your patient are auto-populating on this report. If you click update patient name, there's his name. And then let's go through a couple of these statuses. Really important, okay? So for the statuses, the not signed is not ideal, right? There should be some signature in most circumstances. I forgot is not a great answer. It happens, but it's not a great answer. We really would like to see signed. So if we go down to the bottom, the two choices are signed by the patient or signed not by the patient. Remember that for the purposes of billing, liability, making sure that we have the right information on a report. Signed is the patient, him or herself. Anyone else, including a legal guardian, parent, someone that's signing on the patient's behalf, would be signed not by the patient. So in a perfect world, it's signed. And there's typically 4 things that we're clicking for the patient to sign. Number 1 is the HIPAA acknowledgement or release. This is the patient stating that they received the pamphlet from you, or were at least offered the pamphlet saying that we're not going to share their information with anyone. Permission to treat means that we did some kind of treatment for them. Permission to transport means that we took them somewhere. and then release for billing authorizes us to bill their insurance company. Those are typically the 4 things that we would see. Caveats from this: the person says, yes, it's okay that you can treat me, but I'm not going anywhere with you. That's permission to treat, but refusal of transport. Or the person says, no, you may not touch me, and I'm not going anywhere with you. That's refusal of care and refusal of transport. And of course, those people may very well not sign this as well. But they should. We should encourage them to. Fine, if you don't want to go with us, that's okay. We highly recommend that you do. We are a transporting agency. We want to take you to the hospital because someone or yourself called 911, and we want to make sure that you get the best care possible. If they absolutely will not go, then this is the refusal of care and transport, or permission to treat and the refusal of transport. Those are the 4 for the patient, though, right? Some combination of these 4. So what I've been seeing a little bit of lately is airway verification. I'm not sure where this comes from, but airway verification is signed by the hospital stating that the advanced airway that we placed is in the correct spot. So the transfer of care person would also be the airway verification person. That also would be the person for the transfer of belongings. So if you're giving some belongings to the hospital, that's the person who's signing for the belongings. So airway verification, patient belongings, and transfer of care. Those 3 should be tethered together. Those are all for the same person. If you didn't place an advanced airway, you do not need someone to sign for your nasal cannula. That's not what we're talking about. We're talking about an advanced airway. The controlled substance is administration. This would be our fentanyl, Dilaudid, Versed, and ketamine. If we administered any, the EMS provider would be doing the administration signature. If the full package was not given, so for example, 100 micrograms of fentanyl, 50 micrograms was given, meaning 50 was wasted, then that's where we waste the controlled substance. So those signatures are for the EMS providers. You could have the hospital verify that if that's the person watching you waste the other, but typically we do that as an EMS crew. Others weird, we're really not using it, but it auto-populates somewhere. I'll show you that in just a second. So typical again for the patient: HIPAA, permission to treat, permission to transport, release for billing. Apply. The disclaimers would be if someone says, I'm not going with you, oops, right here, treat and release, or don't touch me at all, denial of care, or if there's some kind of release because of a altered mental status, then those would be the releases, right? Most of the time we just click clear, and then we click sign, and it says on here, these are the 4 things that you're signing, patient. The patient says, I got it, yep. And then Yosemite Sam signs it, and we save it. Really important. There you go. Next on our list is the EMS provider. So I can populate that from the list of crew names. This one is going to automatically populate some of this information when I click sign. I just got one of these back because I forgot to sign one. So this is important. It holds up the billing process. So I'm going to sign mine, and I'm going to save it. And then I'm going to show you something that happens when I do that. This automatically populates the signed not patient because I signed it, but I'm not the patient, right? That's fine. You can leave that. One other thing that's been popping into these under the reason is some of these are auto-populating as other, and it's probably fine. It's not really a huge thing, but when you click on this, and sorry, let me get away from that. I have to look it on the regular signature page. One moment, please. Here we go to signatures. When I actually click on this one with the other on it, if you go down to it, it actually has this treat and release information above my name, which of course is not correct. So I've been removing the other and just leaving it blank for the EMS provider because that's just the EMS provider signing it. There's really no other reason other than the controlled substance that fits what we're doing here. Some people are doing the transfer of patient care, but if you look at that, all that says is that you transferred patient care. I mean, I guess that's okay. But if you leave it blank, that's also fine because you are signing as the EMS provider, and that's okay. Really, the transfer of patient care is supposed to be the person at the hospital that's receiving this patient. So that would be a healthcare provider, and I'm going to clear that right away. Transfer of care and apply. None of those apply. And then when you sign it, should have the name of the person in there first, but they're signing that they're accepting whatever patient. Typically, it's one of those, right? So we can always add that afterwards if we didn't get that person's name before they sign. So it's Mike RN or whatever. Okay. Really important, has to be done at the hospital, but this is what this page should look like. You should have a transfer of care, you should have an EMS provider, and you should have the patient who signed it with some information in here. If the patient is not the one signing, by the way, so Sam's wife is the one signing, so it's signed not patient because she's signing on his behalf, then we still would use the HIPAA acknowledgement, release for billing, permission to treat, permission to transport. Any signature is better than nothing. If we're doing not signed, there should be a documented reason why we did not get a signature in your narrative. So if you don't want to do extra work, then get the signature. Awesome. All right, so this call is over. We got all our signatures. Great job, team. We saved Sam. We are now going to go back through and do our report. So when you're doing this, my recommendation is to be very methodical with it. A lot of times we're finding that fields are left blank, and yeah, is Fireworks the perfect software? No, there's no such thing as perfect software. I promise you that complaining about it is not going to change anyone's mind about whether we're using it or not. No, so it's not ideal in some ways, but there's lots of things that are great about it. So if you go through it in a very organized way, it's not going to take you as long. You're not going to miss all the different fields, and things will be okay at the end of your report, right? So I always start with my vital signs because I need to import those, right? So I'm going to go under my assessment. I go to my vital signs. I wrote down which monitor I was using here, so I grabbed the right ones. Oops, and of course I did not do that correctly. Get data is what we should be doing. It's going to prompt me to do some things right away, right? So I had an emergency response in my primary response area. And then once my arrival at the patient time, which I don't know. Let's just do now for the sake of this conversation, but it's going to yell at me because I'm doing it out of order. I picked a report from a few days ago. So I think it's going to look something like that. Okay. Anyway. Yes. All right. Now we did it. So those are now in. So now I can get my device data. There we go. Find the right monitor. It must be him. Preview that one. Looks right. And one of the neat things with this is you can deselect some of these if you don't want them. One thing I've noticed as far as like the trending goes, when the blood pressure is in the first time, it puts the same blood pressure in all of the time. I don't necessarily want all of those, right? So I can deselect some of these so it's not pulling in so much information, because that 142/85 is really the same blood pressure from one take, and then you're not getting so much of that, right? So same thing down here, on the next page, we probably pulled an additional blood pressure, I'm guessing. You don't have to save all of these. Yep, so here's the 134/77, so I'm going to deselect the rest of these. I really only need a couple of them, and then I don't have to do so much with the vital signs after we import it, and then there's one more, that's fine. All right, so I'm going to import that selected data, and that's going to bring the cardiac monitor data with it as well. One thing to be on the lookout for when you import your vital signs is what happens with the rest of the information on the screen. So we kind of see the quick view of this. So at 1301, there's no blood pressure, but we had the heart rate, we had the respiratory rate, the effort, pulse ox, all that stuff too. But if I scroll down the page, there's a lot more information that they're looking for. So if we put a 3-lead ECG or 4-lead ECG on Sam, the ALS provider should document what was on there, sign us something, usually, which we interpreted. And then the blood pressure wasn't included on this one, but position is not automatically selected. Typically they're laying if they're on the cot. Where did the heart rate come from? Where did the pulse ox come from? There's a pulse ox qualifier, which is typically on room air, or if we put them on oxygen, then select the appropriate device. One thing that's really often overlooked is the respiratory rate. Pulse ox by itself is not a lot of information, right? We'd really like to know how well the person is breathing. So on the top, up the screen here, it does have a spot for it. And if I put in the respiratory rate of 20, then it asks me the effort. And was it normal? Was it labored? Was it rapid? Was it weak? Whatever it was. So his was fine. And then it automatically goes to how alert were they? And we have some other quick things that we could do here. But down here, you'd be going through doing respiratory rate, respiratory effort, any of these things if you use them. And then remember, especially for trauma patients, we should have a GCS. The hospital likes that. It's part of our trauma score. Sam's doing okay. He's a max score, so I can do that. And then the other thing that's not auto-loaded is the qualifier. And really what we're looking for is there some problem with the patient, or is this the legitimate value? And then apply that one. I would say you don't have to do a GCS on every single vital sign, because if the first one is 15 and the last one is 15 and your documentation says there was no variation between that, that's what I do, right? So if I got 10 vital signs that populated in here, I would not put a GCS on every single one, but I would definitely do it on the first one and last one, and then my report would say that this trended the same throughout, right? If you want to go through and add all of them, you can. But really what we're looking for is changes on this, right? So this gives me a pretty good picture of what's going on here. And I actually don't want to keep this one because that's not giving me any additional information. So that's what I'm delivering them with is, is these vital signs with these filled in. And this is really what I'm looking for when we're on this page, is what boxes are filled in here. And I'm pretty happy with that. Okay. Did Sam have any pain? That's important. So now that I went down to the first one, that 1252, same thing. If you did an ECG, you can add that. He was laying. Pulse ox was on room air for that first one. How was his pulse? If it's sinus rhythm, we know it was regular. If we did a blood sugar, we can add that here. And then again, that GCS should have a qualifier. I'm assuming if you were attacked by a shark, you probably have some pain. And many of us get flagged on this one. What scale are you using? Numeric is typically the one that we're picking, right, on a 0 to 10. If you did a stroke scale, here's where you would document it. And then if it's a trauma patient, we can calculate that revised trauma score by clicking that button. So check your vital signs, make sure that they're accurate, make sure that you have all the information in there, because that paints a pretty clear picture. Sam's original pulse ox was 91%, and then we put him on oxygen and it went up to 94. That's important, right? So that qualifier makes a big difference. The other thing in the vital signs is the cardiac monitor. This pulled through. The times are probably not going to match up. We found with some monitors, rather, they're a couple minutes off. So you might have to adjust some, or you could just delete the first few that don't really have any information. You don't have to save all of them, but it is really nice to have all of the pulse ox and heart monitor information. It paints a clearer picture. Definitely the 12 leads are really nice to pull into the report. Okay, so I always do that first. That's just me. If you want to do it in a different order, that's fine. But what we find a lot of times is things that you need to get information from somewhere else, like the vital signs. That's an easy way to do it, so that you have that all pulled into your report. And then if you had this call at 5 p.m. and then you're moving to a different station or going off shift, the information is all in here. You don't have to be calling the station saying, gosh, could you go check the monitor and upload my vitals again? So all of that's already in here. So then you can do this from wherever. So once that's in, I go from the very beginning and I'm going through filling out my report very methodically. I'm starting with incident. I'm going top to bottom. So for example, this was a house. This is the address. If there is an incident facility or location name, you can use that. If there's an apartment, suite, room, whatever, you can use that. This one does not. The NIFRs in this one is already pre-populated for me because someone else did this one. I'm borrowing an old call, and that's why this is approved. You can do it here, or remember, we are doing that a person in the back is writing a report and the driver is doing the NIFRs to make sure that there's no confusion about this. We all can still do the NIFRs. Officers are approving them, they're checking them, but that doesn't mean that the officers are writing all of the NIFRs. So you can still do as much as you can of that, and then someone will be reviewing it. That's built in here, or you can skip it and let someone else review it. We have our dispatch information that I added. If there was an EMD card, we would use that. Unit, emergency response, it's automatically calling for this. So what type of unit are we? We are ALS equipped ground ambulance, which is paramedic, and we're coming from whichever station we're coming from. In this story, this is station 4. Adding our whole crew in there and who's responsible for whatever. So I'm this. I'm not going to add other people because but remember, there is always a driver of the response. There's always a driver of the transport. There's always a lead provider. And then anyone else who is not the lead provider was a provider at the scene. So that could be clicked on there as well, and you get that information. It was an emergent response. They always are because they're immediate. Additional response mode descriptors are here. This is basically saying like this was an immediate response, but it was an alpha, so it was no lights and siren, or it was a Bravo or higher, so it was lights and siren, and we can apply that. And then remember, we can come back to the odometer later, can add 0 here if you want, but we're going to calculate that on the disposition one. These are just some tracking tools that we need. So mass casualty, it was 1 victim, so no. Single, this one was not a motor vehicle, that adds some extra fields. And then if there's any other information we need to add for other services, we could do that. Times, auto-populate. One that I always call, it wasn't working for a while, but the arrived at patient time, I get on the radio and I actually call that, and then they document that for us. It's just one less thing that you have to do. Make sure that these are correct. Mine are off a little bit right now, again, because I'm doing this out of sequence from the monitor and things. But again, this is just for demonstration. Patient, we did most of it. We can also fill in the demographic information if we want to. Any other information you want to add, we can get the patient's address in there. And then phone number, email, belongings, if we had any, please add the belongings. It happens all the time where someone calls the station and says, you lost so-and-so's walker or whatever. Having this information in there and who we left them with, very beneficial. So if there's anything that you delivered to the hospital that was not in the patient's hands when they got there, or even if it was in the patient's hands, you can still use this. Medical history, if we have anything to add, so we're going to say that he didn't have something. We hopefully did this before. Estimating body weight, all great information that we can add to this. This is probably the most complicated part of it, right? Is getting all those allergies and all those medications and all those medical problems. I see it overused or underused rather. Recent travel, if we know it, great. Something lingering from COVID still. Exposure to something, if we know it, great. Shark doesn't count, right? An infectious disease like they had COVID or something like that. Under assessment, this is going to walk you right through everything, right? When did this start and what was their last known well time? This seems a little silly to me because you'd think that if the symptoms started now, the last known well time was 1 minute before that, but that's not always the circumstances, right? So most of the time, that's what I'm putting in here is this symptom onset was, 20 minutes ago, right before they called, which means their last known well time was 21 minutes ago, and that's fine. Anatomical location, organ system, all this information I see used pretty consistently. Remember, the complaint is you adding something in writing that was going on with the person. So shark bite and concussion symptoms. I'm not a doctor, so I can't call it a concussion, but he's acting concussed. And yeah, this happened 20 minutes ago, something like that. How is he? You can give him an acuity, more important in a situation where we have multiple patients, but that's useful. Possible injury, yep. Cardiac arrest, nope. Stroke, nope. Work-related, probably not. And then these are overlooked a lot of times. Remember, just keep going down the page, right? So I did all the things up here one by one. I got all of them done. Down here, I'm adding the activity. It wasn't actually swimming, but most shark bites occur there. Reason for this is more important for interfacilities. And then justification would be, whatever you responded for. Vital signs, it's giving me an error because of the being out of sequence on those. So I already did the vitals, I already did the cardiac monitor. Exams really have to be done. And the thing is, you do them on every patient, right? It just doesn't get documented particularly. One of my favorite features, add new. And I like that lightning bolt, right? Quick assessment. You can do normal for everything and then find the problems that existed, right? So he had a shark bite on this one, and then he had some neurological symptoms. Not done, just kidding. So whatever those neuro symptoms were. And then after I close that, here it is. So then I can go down and I can make the adjustments to it. So neurological, he had, I don't know, abnormal cerebellar function, whatever you come up with, whatever he was doing differently, right? Or down here, whichever extremity was attacked, we can make those adjustments here, right? But make sure you're doing this exam because we are always doing them. We're always checking our patient over, but we can't paint a clear picture without that. On that same token, a lot of these come back with no procedures done, and I'm going to dispute that because on every patient that you make contact with, you do an assessment, which is the adult continuous physical exam, or maybe a pediatric continuous physical exam if they're pediatric. This is part of our protocol. Not really any complications with doing an exam, right? And probably didn't change their life. I did it one time, it was successful. This is always something that should be on all of your reports. Somebody did an exam. When did you do it? You did it once, it was successful. If you did it again and it changed, you can duplicate this and do it again. Again, if you did other stuff, like you did a 3-lead ECG, you can add that one. So on my 3-lead ECG, who did it? Did we have any complications? Usually no. They were unchanged probably. And then which provider did that one, right? So you can add the other things on here as well, but there should be a running list of things that you accomplished. Remember, if you use this, it'd be even easier because you'd have all of that time stamped as you were actually doing it, right? So in particular, some of the airway things, some of the cardiac vascular medication things, stuff like that. And that's, again, that lightning bolt up on the top. As far as medications, we gave them some oxygen, so I just need to fill in the blanks here. Probably give them, 2 liters per minute, and there was no complications on that. And looked like a situation improved. So that should look like that. As far as protocols, if you wanted to use a specific protocol that you used, you can add it here. For the injury, because we checked yes to injury, it's going to ask for the cause of the injury or tracking informations. So there's a bite of a non-venomous animal. Did he have any of these trauma triage criteria? I don't know. Did he get a tourniquet? I think we managed it. I think he's okay. So we're going to say no, nothing there. And then the same thing, there's a moderate one too. This is more information for the trauma registry for the state. If there was some concern on here, we could say this, if we called it trauma yellow would be moderate, or trauma red would be a high risk. So if you called the trauma center and said this is a trauma red or a trauma yellow, you really should be documenting something in this risk. I suppose that's blunt. There was no fall. There was no OSHA equipment because it was not a work-related thing. And then if we did an airway, there's a field for that as well. We did not. We only did medication, so there's no need for any documentation here. Disposition. What did we do? Well, we made patient contact, and we initiated and continued primary care, and we evaluated the patient, care was provided, and we went to a hospital with this AMS unit, right? This is a pretty normal progression. If you do a lot of reports, if you work every day, you probably have this down to a science already. But one thing I recommend is make some notes, right? If you want to have like a flow chart that you use, patient contact was made, that was already in here, but this is pretty typical, right? We initiated and continued primary care. We evaluated, care was provided. We transported this one, and then where did we go? So we went to Summit by paramedic level, it was an ER, and then all that information's in here. Really important, click this button, calculate that mileage, and it'll say, okay, you went from this address to this address, update the mileage. It's going to put that in there now. So now we have that information in. That is mandatory. One other thing that's overlooked, just keep scrolling down the page. How many patients? 1, moved to the ambulance by stretcher, moved from the ambulance by stretcher typically. Position of the patient, this one's missed a lot of times. I get a lot of check marks for this one. Fowlers typically, right? They're on the cot with the head slightly elevated. If they were semi-fowlers, that'd be basically the same thing. Sitting would be like they're sitting on the bench seat. Supine would be that they're perfectly flat. Pretty rare, right? So it should be fowlers and apply. I already called them green. And then these other fields are mandatory as well, right? So EMS transports by ground, transport by scene, typically non-emergent. Disposition instructions provided is only if you leave them somewhere, so that's not the case. We're going to probably the closest, most appropriate, but it's also a trauma center. If you want to add that to this list. There you go. Well, 2 specifically. And then where did we leave them? The ED. There's not a list here. And then anything else you wanted to add. So no lights, whatever. Okay. So if you did an activation, you can add it. But if you did not, then the disposition is the only thing. For payment, Remember that we're doing a couple of things here. Primary method of payment is the only option. And patient resides in service area is another piece of information we're looking for. This is a person who resides within our service area. And then the rest of that will be insurance information. If you have a PCS, a physician certification statement for an interfacility, you can add that information here. Closest relative information, if you want to add it, can be added here. Employer, if it's necessary, there's a transport and supply on here. Most important is that general. And then under other, a couple of important things. Do you want a review requested? You can ask for that specifically. This is a pretty interesting case. I might say, yes, I would like to talk about shark bites a little bit more. I don't deal with that very often. If you had an exposure, you have to add this. If you want to add this, you click this one button and say, do you want to use your default PPE? And it adds your eye protection and gloves for every member of the crew, which of course we are using on every call. Files not necessary, outcomes not for us, but then custom fields, it's going to ask those 3 questions, right? Did you contact medical control? Nope. Critical care? Nope. Opioid overdose? No. Some tracking things that we're looking at. Most of these are typically no. Signatures already done, hooray. And then I write my narrative and save it. And then I click my checkbox, right? So again, the purpose of this is being very methodical, right? Going through line by line. If I miss something, because there are some things that seem like they're hidden a little bit on here, really all that I'm doing is just clicking through in order and making sure that I'm hitting all the right things. If you miss something, you check the checkbox, it's going to send you back again to, but what I found last week as I was reviewing some of these is there was a lot of calls where simple little things were not checked. Technically, if I'm not a member of the crew, and this is true of all your full-time officers as well, if you're not a member of the crew, we're not supposed to be modifying it. We're supposed to be sending it back to you to modify your ePCR. So you have to make sure that you have all the right stuff on here. And this can get tedious, right? If we keep sending it back and we have to keep reviewing it again. So the goal of this will be for you to go through and do as much of this as you can, make sure that you have things right. And then after you're done going through verifying, remember that you can check the box to make sure that you're completing everything and that everything, all the fewest warnings as possible are listed on there. And then a full-time officer will be reviewing it and either opening it back up and letting you know that there's something that's missing or confirming everything is good and sending it on. So I hope this was helpful. If you have any questions, you can reach out. Otherwise, we could do more of these if we want to do more scenarios, or if you want help working on your own. Remember that when you're doing these, the best time to get review on this is after you're writing one. Most officers are the same as me. They're going to say, write it, and then I can read it and give you some pointers on how some things go. Not everyone is going to have the same suggestions on this, but remember there is some critical information that we need to make sure that things are done correctly, legally, and so that we can bill people. So thanks for your attention, and good luck.